Assalamu alaikum. Our lecture today is the secondary amenorrhea, which are three major causes for it, which are the premature ovarian failure, Asherman syndrome, and Sheehan syndrome. Now, first of all, we started by premature ovarian failure. But the objective of this lecture, the student must know the definition, must know the clinical presentation, must know the causes and diagnosis of the premature ovarian failure, Asherman syndrome, and Sheehan syndrome. But nice to know the complications, sequelae, and the treatment modalities of all of these causes, which are the premature ovarian failure, Sheehan syndrome, and Asherman syndrome. What the definition of premature ovarian failure is defined as hypergonadotrophic hypogonadism with the cessation of menses before the age of 40. It's about 1 to 3% of women experience premature ovarian failure. The incidence is lower in the younger women. The FSH is more than 20 to 40 milli-international units per mole in the presence of amenorrhea has been proposed to define it as an ovarian failure. Primary ovarian insufficiency is the same or alternative to premature ovarian failure. They are present with secondary amenorrhea, presence or absence of other autoimmune disorder, and may be associated with other chromosomal abnormalities such as Turner syndrome. These two words are actually synonymous to prevent an unnecessary confusion. The cause of premature ovarian failure, we mentioned before, may be related to other chromosomal abnormality, may be due to X-linked chromosomal abnormality like 45X or Turner syndrome, or deletion of the short or long arm of X chromosome, or may be autosomal chromosomal abnormalities like balanced autosomal reciprocal translocation like trisomy 13-18 with numerous autosomal genes related to ovarian development and translocation. Then the causes of premature ovarian failure, like these, gonosomal or autosomal genes, or may be related to the sudden destruction of the follicles, and estimated that the cause of 90% which are primary. Premature ovarian failure causes still remain unknown, may be due to unknown cause or may be due to other causes we are mentioning. Diagnosis and management of premature ovarian insufficiency. طبعا women coming to us with a younger age group, less than 40 years of age, present with amenorrhea or oligomenorrhea or other form of menstrual irregularities accompanied by hot flushes. Menopausal serum FSH level is 40 international units per liter on at least 2 occasions are sufficient to diagnose the premature ovarian failure or premature ovarian insufficiency. On physical examination, we must rule out other reproductive disorders. We must rule out the general and pelvic examination, including breast, axillary, pubic hair development. Pelvic ultrasound may be necessary if inadequate pelvic examination cannot be performed. Primary amenorrhea can be caused by various congenital disorders such as Mullerian agenesis, androgen insensitivity, and XY gonal dysgenesis. Diagnostic workup of premature ovarian failure, we must depend on the serum FSH level, karyotyping, fragile X carrier screening, serum TSH level, and dual energy X-ray absorptiometry scan. Laboratory evaluation of premature ovarian insufficiency, FSH level to establish the diagnosis of premature ovarian insufficiency, karyotyping when the women less than 30 years of age or sexual infantilism we found, testing for a fragile R1 gene pre-mutation carrier stage, and thyroid stimulating hormone for the hypothyroid state. This is the fragile X mental retardation 1. We must inform the patient when we diagnose her with premature ovarian insufficiency there is a small but significant likelihood of spontaneous pregnancy or pregnancy after ovulation induction. Very low level of AMH. However, this should not be confused with premature ovarian failure, because even women with undetectable AMH levels frequently continue to have regular periods and FSH concentration less than 15 milli-international unit per ml. May be the first sign of embedding premature ovarian failure and could be used as an early screening test, and more research is needed for confirm this. Clinical picture. The diagnosis of premature ovarian failure can be devastating for patients. Long-term effects on reproductive capabilities, general health, anxiety, depression and psychological distress with supportive therapy and psychological and counseling are important. Long-term consequences of premature ovarian failure, all of these: infertility, menopausal symptoms, psychological distress, decline in cognition, decreased sexual and general well-being, autoimmune disorder when it is associated with it, osteoporosis, ischemic heart disease, increased risk of mortality and increased risk of type 2 diabetes mellitus, type 2 diabetes mellitus. Yeah. Clinical consequences of hypoestrogenism: bone mass loss developed rapidly after ovarian failure, vaginal atrophy manifests with dryness, irritation and dyspareunia, less satisfaction with their sexual lives, diminished general and sexual well-being, decreased androgen concentration and sexual dysfunction. Maybe premature ovarian failure may be associated with other autoimmune disease like these: hypothyroid in 8% of patients, adrenal insufficiency, type 2 diabetes mellitus in 2.5% of cases, pernicious anemia, hypoparathyroidism, myasthenia gravis, rheumatoid arthritis and systemic lupus erythematosus. What are the sequelae? The sequelae number 1 is osteoporosis, bone mineral density and fracture risk. Multiple studies have shown that the lower bone mineral density seen in women with premature ovarian insufficiency or early menopause when the age is less than 45 years, due to any etiology, is associated with significantly increased risk of fracture. Peak bone mass is attained by the age of 30 years in women. Prolonged estrogen deficiency before this age result in decreased peak bone mass. Acral and estrogen deficiency after this age result in early bone loss. Treatment by vitamin D: routinely checking of vitamin D level. Recommended daily supplement dose for postmenopausal women is 800 international units. However, if the vitamin D level are found to be low, high doses up to 50,000 units weekly can be administered. Women with premature ovarian insufficiency should take 1,000 to 2,000 international units of vitamin D3 daily. In addition to the vitamin D3, physiological HRT may be needed. Physiologic E2 replacement with cyclical oral progestin 100 microgram per day, transdermal with 10 mg oral medroxyprogesterone daily for 12 days per month. This replacement therapy improves lumbar spine and femoral length density. Transdermal replacement, no additional beneficial effect on bone mass density. Physiologic HRT was superior to oral contraceptive pills in protecting and improving bone mineral density or bone mass density. Other sequelae of the hypoestrogenemia: cardiovascular disease. We must change the lifestyle modification, or we must do a lifestyle modification or change lifestyle. Lipid level must be controlled. Controlling of hypertension and early treatment and diagnosis, and early initiation of physiological HRT. Other sequelae: emotional health. Physiologic HRT, particularly the E2 component, has been shown to elevate symptoms of depression and even lead to remission when initiation during perimenopausal or very early menopause. Among women with physiologic androgen replacement therapy did not worsen or improve quality of life, self-esteem, or mood. Cognitive function. Estrogen is a neuroprotective. Therefore, potential cognitive benefits of HRT in women with premature ovarian insufficiency can only be extrapolated from existing evidence in older women and from non-human animal data. Future pregnancy with autologous oocytes, primary amenorrhea and Turner syndrome impossible, secondary amenorrhea and hypergonadotrophic hypogonadism may ovulate spontaneously and become pregnant in about 5 to 10% of women. And thank you very much. This is the lecture of premature ovarian failure. We will discuss another cause of secondary amenorrhea, which are the Asherman and Sheehan syndrome. We will discuss the Asherman syndrome. What is the Asherman syndrome? Learning objectives of this lecture: to describe the causative factors of intrauterine adhesion, specify the impact of Asherman syndrome on fertility, and summarize management and treatment of Asherman syndrome. The Asherman syndrome or intrauterine adhesion: partial adherence of endometrial surface with fibrotic tissue. Symptoms are related to degree and location of this fibrosis. Asherman syndrome is defined as a complete obliteration of the uterine cavity with adhesion resulting in cardinal symptoms of amenorrhea and infertility, and the incidence of Asherman syndrome and intrauterine adhesion varies between 2 to 22% in infertile women. Geographic variation in Asherman syndrome result from differences in several factors: incidence of both illegal and legal abortion, technique for peripheral and post-abortion evacuation, criteria for diagnosis of intrauterine adhesion, and awareness of clinician, incidence of peripheral infection and genital tuberculosis. Constellation of clinical signs and symptoms. They are presented with pain, menstrual dysfunction in form of hypomenorrhea or amenorrhea, infertility with recurrent pregnancy loss. Causes: maybe all of the causes due to traumatic changes or traumatic effect to the mucosa, may be related to gravid or non-gravid uterus. The gravid uterus, when there is a miscarriage with or without curettage, when there is a postpartum curettage, post-abortion or postpartum curettage, hemorrhage or uterine embolization. And non-gravid, like in surgical hysteroscopy, resection of myoma or polyp or uterine septum, infection in form of genital TB. Endometrial curettage are retained product of gestation or consumption. In this situation, the myometrium is softened by the pregnancy and often accompanied by a low-grade infectious process, and the traumatizing effect of the sharp curating contribute to the likelihood that a full depth of endometrium will be removed. Diagnosis. Diagnosis will depend on history and clinical examination and investigations. The first important investigations done, the hysteroscopy. This is a method of choice for diagnosis and treatment. Another, hysterosalpingograph, which is widely available, detection of adhesion. Saline infusion ultrasound, also for detection of adhesion. Sonograph can assess the endometrial development and area of calcification. Classification of uterine adhesion may be mild, moderate, or severe. Mild filmy adhesion is less than 1/4 of uterine cavity, ostial area, and upper fundus minimally involved. When it is moderate, Adhesion is in 1/4 to 3/4 of the uterine cavity, involved ostial area and upper fundus only partially involved. Severe form more than 3/4 of uterine cavity, agglutinated ostial areas and upper cavity occluded. Primary goal in treatment to restore a normal volume and shape to the uterine cavity. Secondary goal in treatment associated with symptoms, pain, infertility, abnormal menses, prevention of the recurrence of the adhesion. How can we prevent intrauterine adhesion? Following uterine surgery, resection of the intrauterine adhesion, a balloon can be placed in the uterine cavity for approximately 7 days to prevent recurrence of uterine adhesion formation. Minimizing the trauma to the uterus using low energy instrument to ensure preservation of any endometrium, cold knife approach. Hysteroscopic surgery required skilled persons. And we do a clinical hysteroscopic scoring system. Hysteroscopic findings: ethnic fibrosis present or not, the adhesion filmy or dense adhesion, tubal ostium involved or not. Number 2, menstrual pattern, whether it is normal, hypomenorrhea or amenorrhea. Reproductive performance, whether it is a good obstetrical history or recurrent pregnancy loss or infertility. And we put a score for clinical hysteroscopic system from 0 to 22. When there's a high score, this is indicates severe intrauterine adhesion and the outcome is poor. The efficacy of intrauterine device in treatment of intrauterine adhesion: placement of IUD for 3 months is a standard. Specific type of IUD to be used for this purpose remain controversial. Post-operative use of IUD need to be combined with other ancillary treatment to obtain maximum clinical outcome and fertility. Types of IUCD, we put it. Recommended may be Y-shaped, Libes loop like this, and uterine-shaped, T-shape, and those impregnated with progestin are not recommended, suppressing endometrial proliferation. Uterine-shaped IUD consists of stainless steel coiled with wire with copper inside, release anti-inflammatory agent, widely used in China with good result. Then IUCD with progesterone we didn't accept it because it will lead to atrophy, but we need a proliferation. That's why we better to use stainless steel copper type IUCD. Pregnancy outcome after treatment: there is a correlation between the extent of adhesion and pregnancy outcome after surgical treatment. Valley and Sierra, they said mild, there's 81.3% decrease in pregnancy rate. Moderate type 66, while severe type only 31.9%. When there is an endometriosis, there is little or non-functioning endometrium. That's why the prognosis is bad. And thank you very much. This is regarding the another cause of secondary amenorrhea, which is the Asherman syndrome. And later on, we will discuss the third cause of secondary amenorrhea, which is the Asherman syndrome. The Sheehan syndrome. We put a scenario. Sheehan syndrome is very rare syndrome. That's why we discuss only by 2 slides in order to know whether it is a Sheehan syndrome, because it is a cause of secondary amenorrhea. Case scenario: we have a 34 years old female, consulted her gynecologist 8 months after the birth of her 3rd baby because her period has not returned since the birth and she cannot breastfeed her baby. Her laboratory tests were as following. Prolactin level is less than 3 nanogram per ml, FSH level 2.3 units per liter, LH level 1 units per liter, TSH level 0.25 milli international units per liter, free T4 about 5.6 millimole per liter, cortisol level at 8 a.m. 126 nanomole per liter. All of these hormones are less than normal as you show. What is the most probable diagnosis of in this patient? A. And what is the most important causes of this condition? Sheehan syndrome is a complication of loss of life-threatening amount of blood or severe low blood pressure during or after childbirth. These factors can seriously damage the pituitary gland. Sheehan syndrome can present with adrenal crisis, low blood pressure, unintended weight loss, and menstrual irregularity. And thank you very much. All of these related to secondary amenorrhea, which are caused by premature ovarian failure, Asherman syndrome, and Sheehan's syndrome.